matter which unit you work for, fractured mandibles are something you will see a lot of. Although they are often an isolated injury, they may just be one of several injuries that the patient has sustained. It is very important to ascertain the mechanism of injury, as this can give clues to injuries which might be present but are not immediately obvious. Always assess the airway and rule out a head injury. You must ask the referring clinician to document that they have ruled out a head injury before accepting the patient under our care. The vast majority of fractured mandibles are caused by assaults, and this is often fueled by alcohol or drugs. Road traffic collisions, sporting and occupational injuries are also causes, but are seen less frequently. Mechanical falls and accidents as a cause should be accepted with caution, especially in the elderly. In the absence of a well-described trip or fall, for example slipping on ice, you must be suspicious of a more worrying underlying cause that may have precipitated a fall, so you must consider neurological or cardiac causes. And in the elderly, one of the most common reasons for a fall is a urinary tract infection. A pathological fracture is one that occurs in a bone that has been weakened by pre-existing disease, and this is the cause for around 1 to 2% of mandibular fractures. Be suspicious of this when a fracture has occurred due to a very minor injury, during mastication, or even spontaneously. The incidence of jaw fractures caused by bisphosphonate-related osteonecrosis of the jaws and osteoradionecrosis is increasing, and this is one of the reasons why obtaining a thorough medical history is so important. The majority of patients are not seen within the resuscitation area of accident emergency, but you should still bear in mind ATLS principles. If you are called to resus, you will usually be asked to assess the patient from a maxillofacial trauma point of view, and in this case you should focus your attention on airway control and hemorrhage. Bear in mind that a patient is unlikely to bleed to death from facial injuries, and if the patient is severely shocked and the only obvious area of bleeding appears to be from the face, then consider an injury that has not yet been diagnosed. For example, the patient may have an abdominal injury with a ruptured spleen. Drugs and alcohol may cause a patient to have a depressed conscious level, which may mean they do not exhibit the classical symptoms of certain injuries, which means that thorough examination is essential. Your history should be documented completely and accurately, bearing in mind all the points listed here. You must not speculate and only document what the patient tells you, your examination findings and results of medical tests. Bear in mind that at a later date you might be requested to write a police statement regarding your findings and even be a witness of fact at a court hearing. The classical symptoms of a patient with a fractured mandible are pain, especially when talking, swallowing, or any movement of the jaw. They may also complain of altered dental bite and numbness of the lower lip. Often, but not always, the patient is really quite swollen in an area corresponding to a fracture. Pain on swallowing may mean the patient avoids swallowing and appears to drool. Intraorally, an occlusal step may be seen. Opening the mouth may further displace a fracture, which is very painful, so the patient may appear to have trismus. If the inferior alveolar nerve lies in the path of a fracture, then it may be damaged, or the compressive effect of edema may cause decreased sensation in the distribution of the mental nerve. Always document this at presentation. If there is no occlusal step, then localized gingival bruising or laceration may indicate an adjacent fracture. Grasping the lower jaw with both hands, with your thumbs being on the occlusal surface of the teeth and your fingers being on the inferior border of the mandible, you can attempt to spring the mandible, which might help you identify a fracture. This picture demonstrates an obvious occlusal step, which represents a fracture of the left parasymphysis. If a gap between the teeth occurs, it might be perceived by the patient as a lost tooth. Simply by counting the teeth, you can exclude or confirm this. The top picture shows an obvious occlusal step, which represents a grossly displaced fracture of the right parasymphysis. The lower picture is a fracture of an edentulous parasymphysis on the left side. Note how the mucosa is breached with intraoral bleeding. If a fractured mandible is suspected, then an OPG and PA mandible are mandatory. A rule of thumb in orthopedics is to take two views of a fracture at approximately 90 degrees apart. This isn't quite possible with a face, but an OPG and PA mandible will give a reasonable approximation. Sometimes in children an OPG isn't possible, so lateral oblique views are acceptable. CT scans are sometimes used, especially to image fractured condyles, but this is not something that needs arranging at presentation and should be discussed with your second on call. If you cannot see a fracture on X-ray, this does not exclude one. Your diagnosis relies heavily on your clinical examination. It is important to familiarise yourself with the anatomical regions of the mandible. Condylar fractures are classified as diacapitular, as in through the condylar head, condylar neck, and condylar base. The symphysis represents the midline, whereas the parasymphysis lies just lateral to the symphysis and extends to the mental foramen. The other regions are self-explanatory. Fractures are often multiple. A fractured angle and contralateral fractured parasymphysis is a common pattern. The mandibular condyle is the most commonly fractured site, whereas the symphysis is the least common. Case 1 shows a bilateral fractured mandible with a fractured left angle and right condylar neck. The arrows show the location of the fractures and note how the left lower wisdom tooth is involved in the fracture. It is the PA mandible of the same patient, which clearly shows the left angle fracture, but the right condylar fracture isn't clearly demonstrated, which proves how necessary it is to obtain the two different views. Case 2 shows an OPG of a fractured left angle and right parasymphysis. The parasymphyseal fracture appears to be comminuted. The PA mandible also shows both of these fractures nicely. This case shows a bilateral edentulous fractured mandible. Although it is edentulous, it is not atrophic, as the bone height appears to be in excess of 10 mm. This is a PA mandible of the same patient. This type of fracture is sometimes described as a bucket handle fracture. If the bilateral fractures of the anterior segment are unfavourable, then the action of the suprahyoid muscles can pull the fractured segment and tongue posteriorly, which may cause airway compromise. If this eventuality occurs, then it is easily overcome by simply pulling the fractured segment anteriorly. All fractures in tooth-bearing areas are classified as compound fractures and require antibiotics to prevent oral bacteria causing infection at the fracture site. If the fracture is at all unfavourable or displaced, then admission and preparation for theatre is necessary. The admitted patient requires intravenous antibiotics, good analgesia and corticosteroid mouthwash. Paracetamol, non-steroidal anti-inflammatories, and weak opioids such as codeine or tramadol are usually sufficient to dispel the pain caused by a fractured mandible. You must ensure you are aware of any drug sensitivities the patient may have, and remember that prescribing non-steroidal anti-inflammatories to patients with peptic ulceration, renal failure, and some patients with asthma is contraindicated. It is also unwise to prescribe them to the elderly or those on ACE inhibitors. If the patient is to be kept nil by mouth for a while, then do consider starting intravenous fluids. Some fractures do not need surgical intervention. Dental occlusion is a good indicator as to whether an operation is required, but on the whole, any fracture anterior to the mental foramen will need surgical intervention. The management of fractured condyles is controversial, and you are advised to read about this. The Royal College of Surgeons and SOAR group suggest treatment algorithms, and the links are mentioned here. Open reduction and internal fixation is used in the vast majority of cases and involves making an intraoral incision to access a fracture and then placement of titanium mini plates to immobilize a fracture, and this should be explained to the patient. A sample consent form is shown here. You should include extraction of necessary teeth as a procedure in virtually all consent forms, as damage to the teeth or their involvement with a fracture is not always obvious until the patient is on the operating table. The potential complications mentioned here are not exhaustive, but nearly all are relevant to most fractures. You must have a good understanding of the post-operative care your patient will require. The pain must be managed effectively, and usually just 2 post-operative doses of intravenous antibiotics are required. Post-operative X-rays will be required, and these must be scrutinised. It is important to inform the patient that they need to maintain excellent oral hygiene and avoid smoking. You will need to discuss with your second on-call whether or not elastics are required, and the patient will require a soft diet for around 6 weeks. You must inform them to avoid contact sports for 3 months and make sure they are seen in outpatient clinic in a week's time. In summary, the fractured mandible is an injury you will see frequently, and you will easily become confident with their initial management. Remember to assess the airway and always consider a head injury. A good history and examination is important not only clinically but from a medico-legal point of view. If you have admitted the patient who you think needs open reduction and internal fixation, then remember to book them on the emergency or acute theatre list. If you don't book the patient early, then their operation will be delayed.